Good morning, everyone. How's everyone doing? I guess it's been 2 years since we've been in person, so I guess that's a positive thing that maybe COVID is on the recess for a while or perhaps downtrending. It's great to have everybody here. We're going to start out with the chief residents. I'll introduce them and then we'll have a little discussion after each talk. We're privileged to have Dr. Anderson here as our visiting professor. While he's a foot and ankle surgeon, he knows something about everything, including your talks. So all questions are fair game, I guess. And with that, we'll start with Dr. Bailey. Zach, you all. Zach's a Nebraska guy. He is off to Harborview to do a spine fellowship next year. We're excited to hear him talk about some of the things they've done with spine surgery with pain management. Zach, thanks.
Oh gosh, what's happening? Get it out of here. Thanks for the introduction. I'm Zach Bailey. For those of you that don't know me, I'll be talking about opioid prescribing habits after single level posterior lumbar spine surgery. Here are disclosures. We have nothing to disclose. So some background. So as we all know, postoperative pain control is important, but there has been a growing epidemic of prescription painkiller abuse. And this all kind of started back in the 90s. In 1996, the American Pain Society coined pain as the fifth vital sign, and we've been kind of dealing with the aftermath ever since. So now Americans consume about 90% of the world's global opioid supply, while representing only 5% of the world's population. And drug overdoses, now the leading cause of accidental death, with opioids being the most common offender. Of prescribers, surgeons are the second highest prescribers of opioid pain medications, secondary to only chronic pain specialists. And it's thought that orthopedic procedures result in more pain due to manipulation of musculoskeletal tissue, which is highly innervated. And of orthopedic procedures, spine surgery is often regarded as one of the most painful orthopedic procedures. As many as about a quarter to more than half of patients undergoing spine surgery are using opioids preoperatively, and patients undergoing elective spine surgery are at risk for increased opioid abuse or dependence after surgery. There is substantial variation in prescribing, however, and it's estimated in one study that up to 70 to 80% of opioids being prescribed are not actually used after surgery. And so there's been a lot of research looking into this and trying to figure out ways that we can prescribe patients kind of a more accurate amount of pills so that they're just using what they need. You're not over prescribing. Stanek et al. Did show that there was a significant decrease in opioid prescribing in hand surgery after a protocol was implemented, which is partly the basis for this study. And another study found that the mean number of opioid pills being prescribed in lumbar decompression with or without fusion was approximately 107, with a fairly wide range, as you can see here. And currently there's no comprehensive guide or protocol to inform surgeons on how many pills to prescribe after common spine procedures. So the purpose of this study was to determine the quantity of opioid pain pills being prescribed, factors associated with increased opioid use, and the optimal amount needed to treat postoperative pain after single level posterior lumbar spine surgery to ultimately improve opioid prescribing practices. Our material methods, so this was a retrospective chart review. We looked at patients undergoing single level posterior lumbar spine surgery from 2018 to 2019. We separated them into two groups, those undergoing decompression, which includes things like laminectomy, discectomy, microdiscectomy, hemilaminectomy, or intramitted fusion, including TLIF and posterior lateral fusion. Patients were excluded if the surgery was indicated for trauma, tumor, or infection, or if they were minors under 18. So the primary outcome measure was the number of 5 milligram oxycodone equivalents being prescribed initially post-op and then total, including refills. And then some of the other measures we looked at include things like age, sex, BMI, ASA score, hospital length of stay, opioid use within 30 days after surgery or more than 90 days. Within 30 days before surgery or more than 90 days after surgery, the number of refills, quantity of pills refilled, and then pain scores. So this is kind of a big table summarizing most of our results. As you can see that there was significant differences between the two groups in regards to age, sex, ASA score, and length of stay, with the fusion group tending to be older, more likely female, higher ASA scores, and longer lengths of stay. There was no difference between the pain scores between the two groups. Actually more than a third of patients undergoing either decompression or fusion were using opioids preoperatively. And there was a difference between the number of pills prescribed for each group. So you can see that the median number of pills prescribed for the decompression group was about 30, whereas the fusion group was about 50. Patients undergoing fusion required more refills than patients undergoing decompression alone. And then you can see when you account for refills, the total number prescribed for the decompression group was the median was about 40, and the median for the fusion group was about 60. So this is just a graph kind of depicting some of that. This is the quantity of pills prescribed for each group at discharge, refills, and total. And you can see that the red group, the red bar is the fusion group, and that they were prescribed significantly more than patients just undergoing decompression alone. This is some of our correlation data looking at correlation between quantity of pills prescribed at discharge or refills and various factors. And so there was a small but significant positive correlation between ASA score, pain scores, preoperative opioid use, and length of stay in regards to the quantity of pills prescribed. And this is a box chart looking at the quantity of pills prescribed as it relates to preoperative opioid use. And so patients that were using opioids preoperatively were prescribed significantly more opioid pills at discharge in total. And this is looking at the quantity of pills. This is a scatter plot looking at the quantity of pills refilled and the quantity of pills prescribed at discharge. And again, there's a small but significant positive correlation between the amount of pills you prescribe somebody at discharge and the amount of pills that they're going to refill, which I think is interesting. So that basically is in our control. The more pills you prescribe somebody at discharge, the more likely they're going to end up needing a refill. So I think that's an area that we can intervene on. So some limitations of this study is that this is a retrospective study. There's no data that we have regarding how many pills were actually taken or how many were unused. We had kind of some incomplete data on that, and unfortunately weren't able to draw any conclusions from any of it. Pain medications from other sources are not able to be accounted for, so we can only account for what was documented in our system. There's various comorbidities that can contribute to increased opioid use, and they may confound the results. So in summary, more than a third of patients were using opioids preoperatively. Patients undergoing single level posterior lumbar decompression required fewer opioid pills than patients undergoing fusion alone. Preoperative opioid use, higher pain scores, longer length of stay, higher ASA score were all associated with increased postoperative opioid use. And the quantity of pills prescribed at discharge does positively correlate with the quantity of pills being refilled. So in conclusion, or the conclusions that I kind of drew from this study were that by prescribing amount at or slightly below the median value determined in the study, we can meet the pain demands for most patients while reducing overprescribing habits. So I would suggest an initial prescription of 20 to 30 pills of 5 milligram oxycodone equivalents for single level posterior lumbar decompression, and about 40 to 50 pills for single level posterior lumbar fusion, with no prescriptions given beyond 90 days. Here are my references. I'll take any questions.
So what's happening in Michigan with regard to pain management? You think we'll see a day when we get rid of narcotics?
Yeah, it's been very interesting because some of the colleagues at University of Michigan did a very similar study using statewide. And they had a statewide collection of unused opioids. Filled up enough barrels of unused opioids. laid 6 inches of opioids for the entire field, big house. So we found there were a lot of people that were using dramatic.
Mhm.
Their conclusion was maybe some of these unused pills. Now, I think street drugs are so available. There's a lot of overdoses, street theft. Everybody is reeled in. We took that data and pared it down from 108.
Discussion came up. Everybody hear me? No. We started looking at numbers and we went to a 40 pill prescription, and now you have to come in to get a refill, and it has to be picked up by hand. We're finding very few people are doing that. And these are some pretty large, complex foot and ankle cases with multi-level fusions and big realignments. So, we're doing a lot of more multi-modality treatments. So everybody gets an anti-inflammatory now, which we didn't do before. We were worried about the healing effect. We do complementary medications. So we use Flexeril and Celebrex and Tylenol and Tramadol, and we have them stagger it. But our goal is to try and get everybody off narcotics within 7 days.
Not to turn this into a political thing, but I think many of us knew Preston down there. And to see that the patient was struggling with pain. I don't know if we'll get to the day where we don't prescribe narcotics, postoperatively, like a lot of other countries. Certainly a big problem. Okay, Zach,
Thank you.
Well done.
Thanks.
You. We're going alphabetically. Next up is Dr. David Brown. David came to us from Texas. He's a UT graduate, UTMB medical school, and then here for orthopedics. He's doing a sports fellowship back down in Baylor in Houston. And then I think he's pretty close to has a contract down there. So looking forward to your presentation this morning, David.
All right, we'll get going here. My name is Dave Brown. I'm one of the 5th years here. I'm going to be doing my talk on the effects of malnutrition on perioperative complications in patients undergoing rotator cuff repair. Disclosures. Authors, Dr. Tusing, as well as myself. So as far as a little bit of background, there's been a tremendous amount of literature published on the effects of malnutrition in orthopedics, leading to inferior outcomes, increased wound healing issues, as well as infection. Primarily, the research you'll find out there is in the arthroplasty world, the spine world, as well as like hip fractures. Even in our time, I feel like there's been a ton of literature over the course of the last 5 years on these topics. You don't see a lot in the sports world on this, though. So again, it's just kind of sparse out there. So albumin has been recognized as one of the overall markers of, or one of the markers of overall nutritional status and wound healing capacity. There's others as well that people use: prealbumin, transferrin, retinol binding protein. But the one that you see in the orthopedic literature most common is albumin. So the purpose of our study is to determine whether malnutrition as defined by an albumin less than 3.5 grams per deciliter placed patients that have undergone arthroscopic rotator cuff repair at a higher risk of medical perioperative complications, mainly infection, stroke, MI, pneumonia, pulmonary embolism, DVTs, renal complications, blood loss, as well as UTI. And as a secondary purpose, it was to assess the impact of malnutrition on some other operative metrics such as length of surgery, length of stay, readmission, reoperations. Pretty straightforward study. You know, with the COVID coming up, I was looking for a study that I could do that wasn't going to wouldn't have to have access to patients or clinical setting, and so NISQIP kind of lended itself nicely to this time period. So this was done through the American College of Surgeons National Surgical Quality Improvement Program database to identify patients that had undergone rotator cuff repair. The data sets we used were 2012 through 2017. In some ways, it was kind of forced our hand. If back before 2012, they were obtaining different data sets, and that particular range allowed us to kind of have comparable data from the different years. Unfortunately, one of the limitations is that it only provides data that extends out 30 days from that operative period. We identified patients who were malnourished as defined by an albumin less than 3.5 grams per deciliter and compared their data, their labs, their comorbidities, perioperative complications against those that were not malnourished. The sample size was reasonable, 7,688 patients. The malnourished group had 278. The non-malnourished group had 7,410. Again, data to be collected, demographic characteristics, some clinical characteristics, whether they're diabetic, smokers, COPD, CHF, hypertension, they are undergoing dialysis, weight loss, ASA class, as well as operative time. And then again, looking at those perioperative complications as listed. So again, we use that NISQIP database set. Basically, we're able to, I don't know if any of you guys, I'm sure several of y'all have used this set, but you essentially have to put in specific search criteria. So we use CPT code 29827, which is the arthroscopic rotator cuff repair CPT code. And then we're able to group them into malnourished, not malnourished, and compare those different data points and run statistical analysis on them. As far as results, it was honestly surprising to me, given what we see in other orthopedic fields, but there was no superficial surgical site infections in the malnourished group, no deep infections. Really, there were no statistically significant findings in the malnourished group. There was a trend towards some increased pulmonary complications, but again, not statistically significant. There were some findings with regard to length of hospital stay. Again, this is just kind of a graphic representation of the same. And then again, when looking at some of those other metrics, for instance, operative time, length of stay, reoperation rate, as well as readmission, patients with a low pre-op albumin had significantly longer mean hospital stays, as well as increased readmission rates as well. So conclusions that we drew, while there does seem to be an association of malnutrition and perioperative complications in other types of surgery, this doesn't appear to be the case with regard to arthroscopic rotator cuff repair. And patients with malnutrition were found to have significantly longer mean hospital stay, as well as increased readmission rates. Again, there are some limitations of this study. Like I mentioned, we're only able to look at 30 days out from surgery. So I'm sure that you may pick up a few other complications further out. We were also limited in our time frame because those databases changed. But if anything, I thought that this probably catches the worst of the patients, because up until the last couple of years, albumins were not commonly obtained on all of our preoperative patients. Now it's still not obtained on everyone, but it's probably more your high risk patients that they're obtained on. But if anything, this would kind of lean towards overrepresentation of the unhealthy patients, I would believe. So I expected we were going to find higher infection rates, but wasn't what we found.
David, what are your thoughts about why it didn't pick up higher infection risk?
I think it's a good question. I think that this is all database driven. I mean, you have to report it into the database for us to collect the data. And I think there's some flaw there. Anytime you're trying to rely on the database to pick these up, I don't know if there's accurate reporting in every instance. It's hard to say.
You think the comorbidities played a role?
Sure, but like I said, I think that probably those folks who were had the higher comorbidities, the higher risk profiles were probably the ones who were included in the study because they probably are the ones who got the albumin.
That's what I'm saying is, you think maybe the comorbidities were more dominant as a risk factor for infection than albumin?
It's definitely possible. Yeah.
What are your thoughts? When you go forward, you're down in Baylor or wherever, you're gonna assess your patient's nutrition for that?
Yeah, I still think regardless of this data, I mean, you always want to try to set yourself up for success, set yourself up and your patients up. And if they have a low pre-albumin, I still think it's important to optimize them from a nutritional standpoint. But I don't think in the sports world it's as big of a problem. But for you guys, I think it's really important.
Did you stratify why they got readmitted? Was it? They
Um,
didn't have wound problems. Was it cardiac? related?
No, I didn't stratify that.
Dr. Tusik, any comments, thoughts? Probably.
This is, yes, you hit on it. This is a data set. These are not normal people. No normal people get albumins drawn for an arthroscopic coverage. They're already have major comorbidities because I draw zero albumins, have zero intent of ever drawing an albumin on a normal 50-year-old that I'm fixing her cup. The reason infection can't be pulled out is because it's exceedingly rare. I've had 1 in 9 years after a cup repair. So your N on this is exceedingly rare because you're making 5 poke holes around their shoulder and pumping 15 liters of fluid through their shoulder doing the scope. So infections are exceedingly rare. And then lastly, this is a 30-day data set, which most of your infections, if there is going to be one, is going to be C. acnes after an arthroscopic cover repair, which is probably going to show up after the 30-day mark. It's going to be between 4 and 6 weeks and not be caught in this data set. So a lot of reasons. It's an interesting topic, I think more relevant to joints and fracture work, not really that applicable to the sports world.
That's good. Any other thoughts, questions? You're gonna let David off the hook? All right, good job. Thank you. Next up, Dr. Heiden. Jace is also a Nebraska Wesleyan med school here and residency. He's off to Wisconsin next year to do a sports fellowship, but today he's going to talk about hip fractures and early mobilization. Jace?
Well, good morning. Like Dr. Garvin said, I'm Jace Heiden. For those I haven't met, I'll be presenting my research on early ambulation after hip fracture surgery and its association with decreased 30-day mortality. Authors of our study include myself, Dr. Stephen Gooden, who is also a medical student here and is now a resident in Michigan at Grand Rapids. Doctors Mormino, Siebler, Putnam, and Tao, and our statistician, Liz Leiden. And disclosures for our authors are as listed here. So first, some background on hip fractures. They're associated with significant morbidity and mortality with an annual incidence nearing 1.7 million patients. Up to 25 to 30% of these will be deceased by 1 year after their injury. And mortality is 3 to 4 times higher compared to age mass controls in the general population. And about half or more of these never regain their prior level of function. And to put this into scale, an estimated $9 billion is spent annually in our country alone for the management of these injuries. So literature has shown that expedited fixation after hip fracture leads to fewer complications and increased survival, with early postoperative activity leading to improved mortality rates. In long term, the inability to stand, independently sit down, and perform ambulation have proven to be harbingers of mortality. However, to date, there's been a paucity of data in the literature on progression of ambulation in the immediate postoperative period and its effect on ultimate outcomes, with no evidence of quantitative distance walked in relation to mortality. So with that in mind, the purpose of our study was to evaluate 30-day and 1-year mortality following hip fracture surgery in relation to the level of mobility achieved on the first 3 postoperative days. We also looked to stratify mortality based on the distance walked and quantify the importance of early ambulation. And finally, detect any relationships between observed mortality, the comorbidity burden, and the time elapsed from the injury to surgery. So inclusion criteria for our study included a study period from 2012 to 2018, patients being 65 or greater, having sustained a low energy mechanism of injury that resulted in a fracture pattern of a femoral neck, intertroch, or subtrochanteric femur fracture. Surgical treatments under the umbrella of our study included closed reduction, percutaneous pinning, sliding hip screw, cephalomedullary nail, and then arthroplasty with hemiarthroplasty and total hip arthroplasty. For our data collection methods, we looked at inpatient postoperative physical therapy notes and reviewed these, looking for the distance walked in each of the first 3 postoperative days, also at the level of assist and if a walking aid was required. We looked at the admission status and the time elapsed from when they presented to the point of the incision and surgery. We looked at a modified 5-factor index score and tabulated this for each patient. And finally, the mortality status at both the 30-day and 1-year mark from the date of surgery. Briefly, this modified 5-factor index score includes these factors of diabetes, hypertension, congestive heart failure, COPD, and whether or not they have independent functional status. It's a concise barometer of patient frailty, and it's recently demonstrated utility in both the arthroplasty and trauma literature to identify high-risk patients and to guide their care. So to our database, we had a total of 485 patients who met inclusion criteria. 218 of these had appropriate documentation of their ambulation and gait data, and 157 were reported to have walked a measurable distance in the first 3 days. This graphic shows our mortality results with on the y-axis the mortality rate in percentage, and then on the x-axis the left couplet shows results at 30 days, with those being able to walk in the first 3 days having 3% deceased compared to a larger 13% who were unable to ambulate in that period. And then towards the right couplet, looking out to 1 year, we found that 15% who were able to walk in the initial period were deceased compared to the larger 28% who were unable to ambulate from those first 3 days after their surgery. This table shows the effect of our patient ambulation and mortality without looking at the comorbidity burden of our cohort. We found at 30 days that there was an over 4-fold correlation with the ambulation coefficient if patients were able to ambulate in those first 3 days on their mortality at the 30-day mark. And then further out at 1 year, we found that there was an over twofold odds ratio with 2.26 for mortality based on those first 3 days after their surgery. We did also look at the patient status, whether they were an initial internal presentation to our facility or if they were transferred from another facility, trying to detect if any delay towards the time of their surgery had an impact on their ultimate mortality. We looked at statistics in both at 30 days and 1 year and found that this admission status was not found to be significantly associated. Further statistics with regression analysis found that after further analysis with their comorbidities included, we found that there was still a 4-fold increase in difference based on the ability to ambulate in those first 3 days upon 30-day mortality. Further out to 1 year mortality, we found that there was an insignificant difference with the 1.66 odds ratio and insignificant p-value based on the first 3 days of ambulation. Towards that middle column with age, we also looked at the ages of our cohort and found that with the odds ratio of 1.05, that this signified that there was a 5% increase in mortality based on each additional year of the patients. And then finally in that row with our modified 5-factor index score, we found that for each unit of increment from these 5 factors, there was a 62% increase in mortality at 1 year. Both of these last two were not significant at 30 days. So we do recognize several limitations of our study, being reliant upon physical therapy documentation, and with that, a lack of standardized data entry, and of course, the retrospective nature of my study. So in conclusion, we found that ambulating in the immediate postoperative period was associated with an almost 4-fold decrease in 30-day mortality, but that it was not associated with 1 year mortality. We found that the risk of 1 year mortality increased 5% with each additional year of age in our cohort, and that the mortality risk increased 62% for each additional modified 5-factor variable present at the time of their injury. Study was published last year in the Yellow Journal of AAOS, as well as presented as a podium presentation at MAOA last fall. So thank you for your time and attention.
Questions?
So how does this change your practice? Do we push cardiology to clear these patients on the day they come in so that we can get them to the OR that day or the next day?
Yeah, I think that's definitely a contentious subject here with cardiology clearance. We found ultimately here a lot of times with the cardiology delays, it doesn't really change the ultimate outcome or that we're going to treat them with surgery. So, we've tried to be a little more outspoken and get these folks to surgery quicker. I think it certainly shapes the framework when we visit with these patients and their families to kind of let them know the impact that hip fracture does have upon these patients and their ultimate outcomes.
And do you think the cause and effect was how quickly they got surgery that led to how quick they got out of bed? Or were the older, more disabled people just less likely to get out of bed?
Yeah.
post-op day one?
I think the latter. I think their comorbidity burden and their ultimate physiological reserve probably plays a greater impact in that.
Kind of follow-up question there, Jace. One of the reasons to do total hip arthroplasty in this patient, in this population more than we used to, is for early ambulation.
Mhm.
Were you able to look at that as a risk factor, whether they had a total hip endo or fracture fixation?
We looked at those together. I don't think we found any significant difference versus the nail fixation versus hip arthroplasty. We tried to tease those out based on their surgery and didn't find any significant difference in this cohort.
Probably would take a fair number of patients to
Mhm.
sort it out.
Yeah, to have enough power.
Yeah, Kevin, I would just comment on that. We wanted to look at that. So they're actually the overall number of hip fractures is pretty high, but the one we got data on, but it's segment is lower. So just looking at the parts out. But it would be interesting.
Other comments, Matt? Looks like you're ready to make a comment.
Well, yeah, I mean, it's, the hardest thing I think about trying to look at any individual factor. Is there are so many factors.
Right.
Jace did a really nice job of trying to tease out the pre-existing comorbidities and set them aside and look at ambulation as an isolated factor. But truth is, you really just can't do that. It really, it's so many different factors all the way up to how quickly we get them to surgery and all the other things that we're after. Did a nice job of trying to isolate some of those factors.
All right. Congratulations.
Right. Thank you.
Let's move on to Dr. Roedel's. Gordon's came to us from Wartburg undergraduate, University of Wisconsin, residency here. He'll be off next year to do an arthroplasty fellowship at West Virginia. Today he's going to speak to us about total hip arthroplasty in those patients who are 50 and younger. Gordon, please.
My name is Gordon Roedel, and on behalf of my co-authors, Dr. Kildow, Dr. Sam, and Dr. Garvin, I will be presenting our findings on total hip arthroplasty using highly cross-linked polyethylene for a patient population 50 years and younger with a minimum 15-year follow-up. These are our disclosures. The success of total hip arthroplasty in effectively improving pain and dysfunction among patients who are elderly with end-stage osteoarthritis has broadened its indications. And as a result, we've seen a trend over time in which younger patients are undergoing total hip arthroplasty. And compared to this older population of patients, this younger population desires a return to higher levels of activity and requires longer implant survivorship. Historically, the barrier to implant survivorship in young adults was polyethylene wear. With the subsequent particulate debris activating the osteoclastogenic pathway, resulting in ultimately bone resorption, periprosthetic osteolysis, and eventual aseptic loosening. Several investigations looking at 10-year midterm follow-up of total hip arthroplasty with conventional polyethylene demonstrate osteolysis rates up to 56% with 10-year survival rate of these implants as low as 83%. The introduction of highly cross-linked polyethylene has greatly improved the durability of total hip arthroplasty. Midterm follow-up has demonstrated low rates of wear, osteolysis, and implant loosening. A previous investigation of patients aged 50 years or younger undergoing total hip arthroplasty with highly cross-linked polyethylene performed at this institution found low rates of linear and volumetric wear at 9-year follow-up without evidence of loosening or osteolysis. Recent randomized controlled trials have demonstrated excellent wear rates and implant survival out to 15 years in young patients, while others have found similar results beyond 15 years in an older patient population. However, there were no studies that were looking at a minimum 15-year follow-up of patients age 50 or younger at the time of surgery. Therefore, the purpose of this study was to investigate the results of total hip arthroplasty using highly cross-linked polyethylene in patients age 50 years or younger at the time of surgery with a minimum 15-year follow-up. To accomplish this, we set the following clinical, radiological, and wear-related outcomes as our primary and secondary outcomes. We retrospectively reviewed, prospectively collected records of a consecutive series of patients who underwent total hip arthroplasty at an age younger than 50 between November 1999 and April 2005. During that time frame, there were 105 total hip arthroplasties performed in 95 patients who fit this description. Of those patients, 8 hips and 7 patients were lost to follow-up, and 1 hip underwent a revision due to subluxation secondary to small femoral head size prior to reaching that 15-year follow-up. So this left us with 96 hips and 87 patients with a minimum 15-year follow-up for inclusion, with a mean follow-up of 17.3 years and a mean age at the time of surgery of 41.6 years. And these patients either returned for follow-up evaluation or completed a questionnaire if there were clinical data that were incomplete. Of this group, 77 hips among 67 patients had radiographic follow-up, and 72 of those hips had sufficient quality of their radiographs to perform polyethylene wear analysis. All of the total hips were done through a posterior approach. The acetabulum was reconstructed utilizing a press fit trilogy cup, and the longevity highly cross-linked polyethylene liner was used in all patients. On the femoral side, 95 of the patients had a press fit tapered titanium synergy stem, with 1 patient that had a porous coated non-modular prodigy femoral stem. And the femoral head material was chosen based on surgeon preference, which changed over time. And that consisted of 19 cobalt chromium, 34 ceramic, and 43 oxidized zirconium heads. And the bearing diameter of these heads was either 26, 28, or 32 millimeters. Clinical outcomes were measured with the Harris hip score, which was collected preoperatively and again at postoperative follow-up. Each patient's medical record was also reviewed for complications that took place from the time of surgery until most recent follow-up. Radiographs from the first postoperative image to the most recent follow-up were systematically reviewed and analyzed for the presence and progression of radiolucent lines, osteolysis, or change in implant component position over time. And you can see the definitions of each of those listed there. We also, when looking for the evidence of radiolucent lines or osteolysis, assign those to the acetabular zones designated by DeLee and Charnley, or the femoral zones described by Gruen. And then polyethylene wear was measured using Polywear version 8. And this is a validated software that uses AP and lateral radiographs of the hip to provide outcomes on linear and volumetric wear. And so these images, we use the images from 1 year post-op to allow for a bedding in period, and then compared those to their most recent images. And our statistical analysis, we used one-way analysis of variance to compare the 3 femoral head sizes, as well as the 3 femoral head materials, and a paired t-test was used to compare the preoperative and postoperative Harris hip scores. As far as our clinical outcomes, we found that the Harris hip score significantly increased from a mean preoperative score of 52.8 to postoperative 94.8, with a mean improvement among all patients of 42.4. And we found that all patients had an improvement from their preoperative to their postoperative score. As far as complications went, there was 1 deep vein thrombosis found, and as previously mentioned, 1 patient who had undergone revision due to recurrent stability, and that was related to a small femoral head size. However, we did not find any patients that underwent revision due to mechanical loosening or osteolysis. Radiologic analysis found radiolucent lines present in Deleon-Charnley Zone 1 in 23 patients, Zone 2 in 6 patients, and Zone 3 in 7 patients. Our previous head report had found 9 hips with radiolucent lines seen about the acetabular components, and comparison of the individuals identified in that previous study to this longer term follow-up found no progression in their radiolucent lines. Of the hips with new radiolucent lines, 14 were found in Zone 1. And then looking on the femoral side, there were 2 patients who had radiolucent lines and grew in Zone 1 and 7. And these were unchanged from the previous analysis. Those are the same patients with osteolysis in the same, or radiolucent lines in the same areas. We did not find osteolysis present in the hips of any of our patients, and no change in component position, subsidence, or loosening. A total of 72 hips had radiographs of sufficient quality to perform the polyethylene wear analysis. We found a mean linear wear rate of 0.04 millimeters per year and a mean volumetric wear rate of 6.22 millimeters cubed per year. And comparison of the wear rates by femoral head material did not reveal any significant difference between femoral head size or femoral head bearing surface. So to summarize what these results signify, this investigation represents the longest clinical follow-up of patients under the age of 50 with total hip arthroplasty using highly cross-linked polyethylene. We found a very low rate of complications with no revisions for osteolysis or mechanical loosening, and satisfactory clinical outcomes with 96% of patients reporting good or excellent outcomes using the Harris-Hip score. We found a very low rate of linear and volumetric polyethylene wear, which was consistent with midterm wear rates and greatly improved over the long-term wear rates seen with conventional polyethylene. We also did not find evidence of osteolysis. However, we did note radiolucent lines in a large proportion of patients, including nearly 30% of patients with radiolucent lines in Zone 1. However, longitudinal assessment of these radiolucent lines found them not to be progressive over time, and all lines were less than 2 millimeters in thickness. So given the excellent clinical outcomes, the survival and lack of osteolysis, the clinical significance of these radiolucent lines is uncertain. This table just compares the results of this study to those looking at midterm analysis, as well as a slightly older population with the longer term follow-up. And what it demonstrates is that there's a comparable low rate of polyethylene wear, low complication rate, and high survival with our longer term follow-up. This study does have some limitations. So first, 3 different femoral head materials were used in this series, and the study itself was underpowered in order to determine a superiority of one counterface material versus the others. Another limitation is the variety of femoral head sizes used, as well as the predominance of the 28 millimeter head size. Our rationale for selecting head sizes was to allow a polyethylene thickness of approximately 6 millimeters. And studies have since shown that polyethylene less than 6 millimeters is safe and has not been associated with excessive wear or fracture. And then lastly, perhaps most importantly, we did not obtain CT scans on patients for comprehensive evaluation of osteolysis. We didn't see osteolysis on the radiographs, but perhaps that may be an underestimation without quantifying with CT. So in conclusion, this investigation represents the longest clinical follow-up of a large consecutive cohort of patients aged 50 years and younger with total hip arthroplasty using highly cross-linked polyethylene. And it found negligible polyethylene wear, no incidence of aseptic loosening or osteolysis, and excellent clinical outcomes at beyond 15 years of follow-up. We were published in the British Bone and Joint Journal in July 2021, and the next steps with this patient cohort will be to do a 20-year analysis looking at their outcomes. Thank you, and I'm happy to take any questions that you may have.
So Gordon, what are you gonna do with a 30-year-old person that comes to you and has a BMI of 39.5 and has severe arthritis?
So if they've truly got severe arthritis, this data makes me feel a little bit more comfortable about being able to do a total hip. Now, I think in any indication or any instance, I'm going to try to exhaust non-operative measures before I do total hip. I don't think that this is a panacea that says that we can just put a total hip arthroplasty in any patient and they're not going to have any issues going forward. I think we still have to be pretty selective. I think we have to think about things like nutrition, about obesity, there's more factors that go into it than just the polyethylene is what I mean to say.
If you think back to when this, so cross-linked polyethylene kind of introduced in '98, so this kind of started then. So
Mhm.
I think there was a lot of anxiety about the long-term result going to be because it was a new material.
Yeah.
But of the new materials at that time, at least it was a material that if it failed, we knew what the result
Mhm.
would be.
Correct.
As opposed to metal ion release and ceramic.
Mhm. Yeah.
Very good study.
Thank you.
Yeah, I'm a total ankle guy. Yeah, but
What do you think of cross-linked poly with your ankle?
well, we follow the joint guys, so we're always happy to see long-term follow-up with hips and knees that aren't showing a lot of loosening and poly wear because we're just not far enough out with our data collection and we don't have anywhere near the numbers that the hip and knee guys have. But it's always encouraging. Our average age, there's a minimum age in our world that around the country kind of hovers around 60. And I think it probably did that in total joints back in the 70s and 80s where you just knew they were going to wear out 5 or 10 years. But every time a paper comes out and gets published in a major journal that contradicts that and maybe brings that down, I just think it gives so many people more options. And whether it's a combination of really good surgery, very low infection rate, very low dislocation rate, good biomaterials. Maybe it's the biomaterials that are getting better. I don't know, but there's a lot of experience in total hips and total knees that I think the rest of the orthopedic community is really drawing after, and that goes to all aspects of it. We're using your DVT data, we're using your early mobilization, your early weight bearing data, because the numbers are just so much more significant. So I think that's a great study you did. Congratulations.
95 to 2005, there were so many changes going on in arthroplasty. Some of those changes. Crossing polyethylene. Next question, we have a comment or? Some of the problems of the early problems with high cost poly was the compromising mechanical properties with crossing. Right. That was a concern. And that was solved eventually technologically by stabilization with antioxidants. I presume this is with an antioxidant to not compromise the mechanical properties. And when you start introducing the ankle, so I have a question for Dr. Anderson. I'm amazed at how the ankle sees almost the same forces as moving hips and smaller contact areas, so the stresses are higher. And therefore, theoretically, that risk of using highly crossing poly with potentially compromised mechanical properties should be more regarding fatigue. So have you ever thought of that concern? Where is the ankle community regarding that?
Yeah, probably has to do with the surface contact area too, is completely different, right?
Yeah. So I'm old enough to remember the agility was probably the first implant that gained popularity in the United States, and that implant resurfaced into the fibula to try and gain more surface area. So you had to do a syndesmotic fusion just to prevent that motion segment across the syndesmosis. And the goal was exactly that. We need as much surface area as we can. The bones are fairly small. And we also have blood supply issues down in the ankle that we don't deal with in the hip and the knee. So you got a talus bone that gets its blood supply from several areas. And many times they've got subtalar arthritis, and that may have been violated with a subtalar fusion, and the talonavicular joint gets worn. So we're doing total ankles in people with some real complicated deformities and some complicated combinations of arthritis, and the blood supply to the talus gets compromised. Yeah. So we haven't been able to get far enough out to think about poly wear as the main source of failure. And we're just now getting to that point where we've got good 10-year data that shows implant stability, good alignment, good ingrowth, and we're starting to see poly wear for the first time. Usually it's catastrophic failure early in the first few years. You know, so again, we we don't have enough data. We're all using vitamin E impregnated, highly cross-linked oxidized polyethylene right now, but in the first 10 years, that's the least of our concern because we're still trying to get through the initial learning curve.
Good, thank you, Gordon. Batting cleanup from Kansas. Dr. Tingle, Kansas undergraduate medical school here for orthopedics. He'll be going to San Diego for sports fellowship, and you need to all wake up because this is a very important topic of sleep deprivation. Matt?
Thank you. Thanks, Dr. Garvin. I know everybody's on pins and needles for this talk, so let's bring it up here. All right. Thank you, Dr. Anderson, for coming down here to listen to us to present today. A special shout out to my dad who's here today and my family listening on Zoom. So my name is Matt Tingle. I'll be presenting our study sleep improvement program and academic performance. Me, myself, and RJ Barber, Kari Nelson in the GME office, Liz Wellstant, Dr. Koningsberg, Liz Leiden, our statistician, and Dr. Tao. Here are our disclosures. Actually, I do have one disclosure. I do love sleep. As you can see, I even like falling asleep while eating pizza when I was a kid, one of my family's favorites. So that is my disclosure. I do want to actually acknowledge the UNMC Medical School for actually funding this project. This would not have been able to be performed without their funding. So we are a special shout out to them. So we'll talk about sleep and healthcare, the purpose and the methods that we went about for our study, as well as the results that we found and the conclusions we can draw from it, and then future directions for this topic. So as you might imagine, as everybody in this room probably knows, sleep deprivation in medicine is a growing topic. It started in the 80s and 90s, and in 2003, the ACGME office or the ACGME made changes to the workout restrictions, kind of a global regulations, making it so you could only work 24 hours plus 4 hours at the end of the shift for a handoff, as well as you could only average 80 hours of work per week over a course of 4 weeks, and then you needed 1 and 7 days off between that. And then they even went a step further in 2011 and said, okay, well, the first year residents can only work 16 hours, 24 hours for everybody else, but you had to have a minimum of 14 hours off in between shifts. In 2014, 2015, the first trial was performed, which was over 120 different general surgery programs across the country. And they took what was initiated by ACGME in 2011, they took half of them and applied that. And the other half, they said, there's no restrictions whatsoever. And based off what they found in that trial is that there was a non-inferiority of patient outcomes, patient mortality, and overall resident wellness. And so in 2017, the ACGME went back and said, okay, well, based on this data that we have, we're going to go back to 24 hours plus 4 hours for everybody. And then you just have to have 10 hours off in between, keeping with the 80-hour work week and 1 and 7 days off. So what is optimal sleep? So if you look at the National Sleep Foundation, optimal sleep for anybody 26 to 64 years old, which is probably most people in this room, is about 7 to 9 hours of sleep. And if I probably asked a lot of you, you probably don't get that much sleep per night. So what is sleep deprivation? So according to the American Academy of Sleep Medicine, acute sleep deprivation, which is a few days or less as they define it, is significant reduction in sleep time. Chronic sleep deprivation, which is what most residents have, aka insufficient sleep syndrome, is sleep restrictions that persist for greater than 3 months. So what do we know about it? So chronic restriction of sleep, which is about 4 to 6 hours per night over the course of 14 days, has a significant cumulative dose-dependent deficit on your cognitive performance on numerous tasks. And we know that psychomotor fatigue, which is your fine motor movements, your ability to control your body in space, is affected most by sleep deprivation. So how does that affect sleep in medicine? So there was actually there's a couple of studies several years ago. One was very interesting that people like to quote is they actually took intoxicated surgeons above the legal limit of alcohol and sleep deprived surgeons coming off a 24-hour shift, and they had them perform laparoscopic techniques on a simulated lab. And they actually showed that intoxicated surgeons were faster at performing things compared to sleep deprived surgeons. But there really isn't any as far as evidence to inform kind of the issue of how this affects surgical performance. So there's a lot of unanswered questions. As you have this 2011 reform that the ACGME implemented on duty hour restrictions, And it really didn't show anything as far as per the first trial that there was any improvement in patient care or resident well-being. A lot of the literature tends to focus on this negative effect and then the negative detriment that this hour restriction has and regulations have on graduate medical education. But there really hasn't been anything done to kind of spin that and say, okay, well, if we can show positive correlation or show that sleep can actually improve how you perform, maybe we can get better outcomes for our patients, be able to perform better. And so that's where this kind of spurred from. And then you add in this article by Sherry Ma in the Sleep Research Society Journal in 2011. So what she did is she took the men's and women's D1 basketball programs at Stanford University, and she collected their baseline sleep data for about 4 weeks and then implemented a sleep extension program the next 5 to 7 weeks after that. And she used basic sports statistics, looking at their sprint and sprint times, shooting accuracy, free throw accuracy, 3-point field goal percentage, et cetera, as well as their reaction time, and then evaluated their overall sleepiness and their mood. And what she found was that as their sleep increased, they had faster sprint times. Their free throw percentage and 3-point field goal percentage went up by almost 9%. Their mean reaction time improved, and their sleepiness scores decreased, and their mood improved. So they concluded in their study that this sleep extension can actually boost your performance, and that optimal sleep is beneficial in achieving that peak performance. Well, that's great. Well, that's athletes, right? So how does that even relate to physicians? Well, if you look at all these athletes at the kind of peak of their game, LeBron James, Roger Federer, Serena Williams, excluding Tiger Woods, but we are able to see that they get anywhere from 10 to 12 hours of sleep. And so if these people that need to perform at the highest level have to get this much sleep compared to what the Sleep Foundation tells you, maybe there's something to that, considering we're taking care of patients in critical situations, life or limb situations. We're making profound impacts on patients and under stress daily. And so this is something that maybe there's something similar. So here comes where our study comes into play. So we wanted to investigate the impact that improved sleep quality and extension can have. And we started with something simple, which is what we could measure in first-year medical students here at UNMC. So what we wanted to look at is their primary outcome was the raw test scores. And this was based on the standard examinations with the UNMC curriculum. And then our secondary outcomes were going to be mood evaluation using the profile mood stage, which I'll talk about shortly, and the Epworth Sleepiness Scale, which I'll also talk about shortly. So our hypothesis was that improved sleep quality and extension will significantly improve test scores, mood, and daytime sleepiness. Makes sense, right? So the way that we went about this, initially we set out to get 20 first-year medical students. Unfortunately, we were unable to get that many students when we essentially presented to the entire M1 class here what are kind of a general idea of what we were doing. We didn't tell them exactly what our final outcomes we're looking at, but we wanted to kind of give them kind of, hey, this is what we're looking at. Are you interested? So we unfortunately only ended up with 6 first-year medical students that were willing to participate. And this enrollment was purely voluntary. We unfortunately did lose one of the medical students to incomplete data, which I'll talk about in a little bit. So we ended up with 5 total. This was over the course of the spring 2020 semester, so 10 weeks. So we got 4 weeks of control data and 6 weeks of intervention data. And then we had the subjects log their sleep in a sleep diary for quality control. So they wore these actigraph monitors on their 24/7 on their dominant wrists. It's kind of like a Fitbit on steroids. It has accelerometers in it. It has devices that can track their ambient light. And so we were able to monitor that and have that on them for the entire time of that 10 weeks. And then we got their grades from the spring 2020 semester. We had their sleep logs. And then we had the Epworth Sleepiness Scale, which is a survey that we gave at the beginning and end of semester. So we had 2 of those total. And then we had our profile of mood states, which we gave weekly. So we had 10 of those total per subject. So the Epworth Sleepiness Scale is a self-administered questionnaire, and it's actually been well validated and studied to determine the general daytime sleepiness of subjects, whether they're performing simple tasks like sitting here and listening to me talk, watching TV, driving to work. And it was a scale of 0 to 3, 0, no chance of dozing off, 3, a high chance of dozing off. And so it's actually been studied fairly well and been used commonly in sleep studies. And so we were able to use that in our study. And then the profile of mood states is a little lengthier. So this was given weekly. And so this had 65 mood descriptions that they went through and said, I'm not at all likely to feel that mood, or I'm extremely likely to feel that mood. And then this calculates it based on these 6 subscales of tension, depression, anger, vigor, fatigue, and confusion, and calculates a score. The lower the scores, the more stable their mood and less likely to have mood swings. So for the 4 weeks, we had them do self-selected habits, take their sleep logs, do their surveys, and then we implemented our intervention, which was a sleep hygiene improvement through the actual intervention itself was a PowerPoint. Here's one of the slides from our PowerPoint that we gave to the subjects in our study. And then weekly, when we sent out the profile of mood state survey, we actually reminded them to encourage them to continue to work on sleep and kind of reinforce that, essentially coaching them along the way. So we were able to take all that actigraph data and the sleep diaries, and we compared them for accuracy. And then we took the actigraph data and used what's called the Cole-Kripke algorithm, which is the software that comes with the actigraph that's also been well validated and studied. And we're able to withdraw information like how many times did they wake up? How was their efficiency? How long did it take before they fell asleep? How long did it take, or how long were they awake when they did awake in the middle of the night? Things like that. And then so we were able to take all that information and we used paired t-test in order to compare the pre and post intervention differences in those different data points. And so here are our results. So what we found is that our primary outcome, which was the subject's grades, they actually statistically significantly improved from 96% to 92%. Our secondary outcomes, the Epworth Sleepiness Scale scores changed and dropped 2.6 points, which was statistically significant. And the mean clinical important data, meaning the data that you needed in order to prove that it was a significant change, is -2 to -3. So this did fall in the range of clinical importance for that score drop. Our profile mood states score did drop 4 points, but this was not in a statistically significant manner. But we did have a decrease in their mood, which is a positive thing. And then if you look at their actigraph data, their number of awakenings, interestingly enough, did increase per night. So that was statistically significant, but their total time in bed did increase and their total sleep time did increase, but these were both not statistically significant. So what does all that mean? So I think from that data, we were able to say the sleep improvement program significantly improved the raw test scores and the daytime sleepiness in first-year medical students. We were unable to conclude that this changed their overall mood in a statistically significant manner, but we did see improvements in their overall sleep time, time to bed, things like that. So advantages of this study is we'd actually had 100% actigraph and sleep diary compliance of our subjects, which was awesome. We used clinically proven and validated monitoring systems, including the surveys and the actigraphs. We were able to avoid recall bias by quality controlling the actigraph data to the sleep diaries. And we were able to implement kind of what we set out to do and successfully study it. Obviously, there's going to be some limitations with this study. It's a small pilot study. We only had 5 subjects. We had small enrollment. Some of that's probably because these subjects didn't really want to wear this bulky device on their dominant wrist 24/7. The grades comparison is, I think, something that we're currently working on. So if you look at their grades, they improved from the first half of the study to the second half. Well, is that just because the second half of the semester was easier tests, or was that because the first half was a harder test and that's the reason it improved? And so what we're doing is we're actually talking with the medical school to see if we can get the averages for the entire medical school or the entire class over that period and compare them. There's obviously some self-selection bias in this study. These subjects, were voluntarily enrolled for the study. And then there's obviously the observer bias as well. They know they're being monitored. They have this giant the device on their wrist monitoring their sleep. So they kind of know generally what we're trying to look for. So there's a potential for that observer bias. So future projects, I think that there's something here. I think that if we can get to more fashionable, sleeker devices that they're more willing to wear, and that they can wear for longer periods of time and collect the same amount of data, if not even more. I think that's something that we could look at. Obviously, I'd like to use it on a bigger group and for an extended period of time. COVID had a negative impact on that as well. And then you can implement it into surgical specialties and then start looking at their overall performance on arthroscopic simulation or their basic skills. So that's something that you can use with this as well. So I've presented this at the podium for the UNMC GME Research Symposium for a few years now. Plan is to prepare the manuscript and then submit to AAMC, CEA, MAOA, and American Academy of Sleep Medicine. And then hopefully, like I said, is to apply this as a pilot study that can be used across the field of medicine and medical training. Once again, thank you for the UMC Medical School for funding this. Here are my references, and I'll gladly take any questions. So that's one of the things. So there's a couple devices. I don't know how many people are familiar with Whoop, but I've actually contacted Whoop, and that's a device you can actually hook to your bicep or your ankle, and it actually monitors the exact same stuff. It's not as studied as Actigraph is, but you can monitor oxygenation, heart rate, and things like that. And so that's something that you can just move from your dominant wrist to the bicep, and they've shown that it's actually the same. There's no change in the data. So I think if you're going to do that, like you said, if you're going to do it in surgeons, you should do it on something where you can wear it still while you're operating. And then you could actually even track like the stress you're under while you're operating, your heart rate variability. I know there was a recent study in arthroplasty showing that you have the most cardiovascular intense exercise when you're putting in a total hip. There was a recent article that came out about that, and that's kind of similar how they studied that. So